This conference will now be recorded.
Yeah, good morning, students. So today's class is about portal hypertension. It is more of a medical cause, but there are some entities in portal hypertension that are related to surgery. When there is a sudden abrupt bleeding from any open vessel, a surgeon should intervene. So it is important for a general surgeon to know about portal hypertension, the etiology, and the management part. So in my last class, I think I have shown you cholecystectomy video. So I am continuing the liver part, and I think your classes are starting from December. That is, college is starting from December. If possible, if the classes are being taken here, I'll continue the liver part and take the liver infections and inflammatory conditions of liver. So coming to portal hypertension, by definition, always remember it is a portal pressure higher than 5 mm of Hg. So there are some cases where you come across 8 to 10 or more than 10 mm Hg of portal pressures. So these higher pressures develop the portosystemic collateralization. So this is why in portal hypertension there is esophageal varices. So the patient always develop collateralization due to the higher portal pressures. So coming to the categorization of the portal pressures, if there is more than 12 mm Hg, chances of variceal bleeding is high. So if the pressure is more than 15 mm Hg, there is a brisk bleed which stops after the pressure subsides. But when the pressure is more than 20 mm of Hg, there is a chance of continuous bleeding. These parameters vary, but this is the defined part in your textbooks. Coming to the anatomy, so the portal veins arise from the postduodenal plexus of the embryonic vitelline veins. There are only few veins in the body which have valves. Those are present in the lower limb. For example, deep veins of the calf, etc., have valves. This promote pumping of blood against the gravity, as veins dump the blood into the heart against the gravity. So these lower limb veins have valves. So in the adult portal vein, like the rest of the body, there are no valves present. And always remember, portal vein provides 75% of hepatic blood to the liver, and about only 50% of that is the oxygen delivery. So hepatic artery is important, but always remember blood supply to the liver, 75% of the blood flow is through the portal vein. This is the only anomaly where vein takes over the blood supply more than the artery. That is in the liver. That is portal vein. So the portal vein trunk is about 4 to 8 mm, 8 centimeters long. The average length is about 6.4 centimeters, and it is about 0.5 to 1 centimeter in width. And again, it is formed behind the neck of the pancreas at the level of second lumbar vertebra. The surface anatomy is very important because during intraoperatively, these landmarks come in handy. So it is by the confluence of superior mesenteric vein and the splenic vein. SMV and splenic vein, they converge and form the portal vein. So this is a picture depicting it. So this is the superior mesenteric vein. and this is the splenic vein. These two combined to form the portal vein. So coming to the pathophysiological part, there are different entities which leads to increase in portal pressures. So one of that is if there is a block in the portal flow, there is obviously increase in the portal pressure. This same applies anywhere in the body. When there is an obstruction, the pressures increases. So another pathophysiological part is the splanchnic vascular bed response. So splanchnic circulation, there are different entities where uh, increased pressures are noted due to various reasons. So one of those are, so when there is an increase in vasoconstrictor and decreased vasodilator responses, this leads to intrahepatic resistance. So that is one of the cause for increase in the portal pressures. When the vasodilator response dominates, the splanchnic inflow increases. So this leads to the development of portal circulation and systemic circulation. So always remember, when there is an increased vasodilatory response, there are chances of collateral development, be it anywhere in the body. So these are the varices that are developed. So this is the portal vein. These are the short gastric vein. This is the splenic vein. This is gas hyperploic vein. So whenever a portal hypertension person is asked, you should always remember which veins form the splenic vein. So a vague diagram should always be depicted in your answer sheet. Not that tough. Just remember SMV and splenic vein confluence to form the splenic vein. Draw a lever and draw these two veins converging into a splenic vein. So that's more than enough. So when coming to the causes, they are divided into three parts, that are prehepatic, hepatic, and posthepatic. So the prehepatic parts are the portal vein thrombosis. So before entering the river, that is again divided into pre-sinusoidal, sinusoidal, and extrahepatic vein in the hepatic vein. So in the extrahepatic phase, there are portal vein thrombosis, malignant occlusion. For example, if there is a metastasis and the mets are traveled through the blood, that is called as hematogenous spread. So through the hematogenous spread, when there is a malignant occlusion, that can lead to again increase in the pressures. Congenital, some patients will have congenital stenosis. So this can again cause increase in pressures. And the other forms are the sepsis, trauma, and splenic vein thrombosis. In very rare cases, splenic vein thrombosis should be intervened. The pre-sinusoidal causes are schistosomiasis and congenital hepatic fibrosis. These two are inflammatory conditions. So pre-sinusoidal, always remember, they are inflammatory conditions, that is schistosomiasis and congenital hepatic fibrosis. And at the sinusoidal level, always remember it is at the cellular level. So these are cirrhosis of the liver. Be it any type of cirrhosis, cirrhosis of liver is at the hepatic cellular level, that is at the sinusoidal level. And at the hepatic vein, it is Buchiari syndrome and vena occlusive diseases. So this you should remember, and this you should be able to draw in your exam. So if you draw this, you don't need to explain everything to your examiner. It is self-explanatory. As I have already said, the prehepatic causes. And always remember, prehepatic causes are easy to intervene. So intrahepatic, I have already told you about the cirrhosis. The most common cause of portal hypertension is alcoholic cirrhosis at the sinusoidal level. This is due to the cytokines and TNF alpha that stimulates the endothelial vasodilators and prostacyclins, which causes increase in the pressures at the splanchnic circulation. This leads to splanchnic hypertension. This leads to increase in the portal pressures. This leads to increase in the collaterals. So that's how uh, collaterals are formed. So again, another important thing is this: you should always remember. Very important point is deposition of collagen in the space of this. This the mere term of space of this should be present in your paper again. So there are some terms which let the examiner to focus on the paper. So such are these, which is the previous slide I have showed you in a diagram. So if you draw this, the examiner won't read your entire paper. So if he sees this in your paper, he'll know that you have written well. So one of that is the space of this. This is space between the hepatocyte and the sinusoid. So when there is a collagen production, collagen accumulation here, what happens is due to non-perfusion of the arterial and venous blood here, this leads to increased pressures again. The extrahepatic part is Buchiari disease and other things like right heart failure, pericarditis, tricuspid insufficiency. These are all cardiac causes which can lead to extrahepatic cause of portal hypertension. So coming to the evaluation, so whenever a patient comes to you, you'll always have some kind of hematemesis or majorly it is hematemesis, at least one episode of hematemesis in his history. So then you go for your LFTs. You order for a liver function test. So depending on that, you go for an ultrasonography or MRI or CT, etc. So the most common presentations are always jaundice. Hematemesis is more commonly present. Jaundice, ascites, and encephalopathy and malnutrition are end-stage liver diseases. So if the patient present to you with ascites, jaundice, and malnutrition, you can clearly say by looking at a patient whether he is having a liver-related illness, because the patient will have jaundice dice and a pot belly. The patient might be lean, but he will have a very big belly. So that indicates an ascites or a cardiac related issue. But majorly, when the patient has jaundice and ascites, you can clearly make a diagnosis that it is related something or other to the liver. So based on the other parameters or serological assessment, you can go for, if it is if you are suspecting it as an hepatitis, you go for serological markers. For every hepatitis, there are specific serological markers. Based on your assessment, you go for those testings. And in primary biliary cirrhosis, you go for anti-mitochondrial antibody assay. In hemochromatosis, you go for iron studies. In cirrhosis of liver, again, 1-alpha antitrypsin, you order the test for that. And in Wilson's disease, ceruloplasmin levels are ordered. And again, if you are suspecting a malignant disease, AFP, that is alpha fetoprotein, is very indicated and sensitive for assessing a malignant disease. That is hepatoma. Hepatoma is also called as hepatocellular carcinoma. Oma means tumor. Always remember that. It can be benign or malignant. Oma means tumor. So there are again different staging systems. So to assess the stage of the liver disease. So whether it is in an early stage or whether it is in an end stage, you base it through your assessment tools that are Child-Pugh score and MELD score. So these come in handy when you are assessing a patient based on the blood investigations or serum liver enzyme levels. So this is Child-Pugh score, very important. You will come across it through your entire MD or MS life, post MBBS also. So Child-Pugh score, the parameters are serum bilirubin, albumin, prothrombin type, ascites, and encephalopathy. These five are the components present in the Child-Pugh score. So based on the parameters and the levels, you give 1, 2, and 3 points. So if there is serum bilirubin less than 2, it is 1 point. If the bilirubin level is 2 to 3, it is 2 points, and serum bilirubin level less than 3, it is 3 points. So when the levels increases, the stage of the liver disease also increases. Do you want to note down or can I continue? If you want to make a note, this is important slide in the entire presentation. So based on that, you grade the disease into grade A, B, and C. If your points are 5 to 6, so you assess the prognosis of the patient. That is less than 10% mortality in surgical procedure. When you go for surgery, if the Child-Pugh score of 5 to 6, there is mortality chances less than 10. When it is 7 to 9, there is intermediate risk. And when it is grade C, that is 10 to 15%, 15 points, it is very poor and the mortality uh, during the surgical procedure is high. That is, the patient has a high chances of on-table death. On-table death is a meaning. It means that the patient can die on the operative table. Because in end-stage liver diseases, the what do you call? You are giving certain drugs for the patient to be anesthetized. So these excretion and metabolism doesn't function in an end-stage liver failure patient like in a normal patient. So this causes toxicity in the body. The patient can die on table. So it is very important for a surgeon. Coming to other investigations, ultrasonography will give you a vague idea whether it is a liver abscess or a hepatitis. In hepatitis, you can see nodular surfaces on the liver. So a vague picture, ultrasonography will always give you. So if there are focal lesions present, which with what do you call increased vascularity to the lesions, so that suggests to a malignant cause or that is hepatocellular carcinoma. So based on ultrasound, there are it can guide you towards certain diagnosis, but it is not the most sensitive test for determining the disease. Based on that, you go for other tests. So CT and MRI are always the best choices that are present radiologically. But for any tumor, for any detection of a disease, liver biopsy is the better one because you have a histopathological approach. You cannot go wrong there. So the sensitivity and specificity of a HP report or a biopsy report are very high when compared to other investigations because you don't see the liver tissue in detail in ultrasound or in CT. You just know whether it is an enhancing lesion or an non-enhancing lesion. So based on that and certain parameters, you come to a conclusion. But in biopsy, you always see the morphology and the structure of the cell. And while doing ultrasonography, you can always go for Doppler study of the portal system. So this gives you a vague idea about the increased pressures or decreased pressures, or if there are any obstructions in the portal system. So in that way, Doppler can be used. Coming to angiography, so this is based by measuring the wedge pressures at the free hepatic veins. So the difference in here is known as the hepatic venous pressure gradient (HVPG). So this is done by a balloon occlusion technique, similar to the Swansgan's catheter. So Swansgan's catheter is a certain type of catheter. I don't know how to explain it to you without a clear picture about it. So the normal HYPG is a 6 to 8 mm of Hg. That is, hepatic venous pressure gradient is about 6 to 8 mm Hg. That is, if it is between these things, there are less chances of developing any serious illnesses. But in cirrhosis and all, it is greater than 10 mm of Hg. So when the pressure gradient increases to that levels, the sclerosing effects and the cirrhotic effects come into the picture. Excuse me. If I could, I will show you the Swansgan catheter, but it is commonly used in the pulmonary catheterization of the pulmonary artery. So just remember that if there is a chance, I will show you in the coming classes. So another most important and by default, you should always, when you are suspecting a portal hypertension case, should always order for an upper GI endoscopy and do an upper GI endoscopy for the patient, because all patients with cirrhosis should have some kind of collaterals developing around the esophagus and some kind of mucosal damage that is happening in them unknowingly. Even the patient doesn't have hematemesis, there can be some chances impending hematemesis can be detected. So about 30% of patients with cirrhosis develop portal hypertension. So that is one of the reasons. 30% patients with portal hypertension will bleed from varices within 2 years. So these 30% of patients will have a higher risk of bleeding in the initial presentation of 2 years only. So you should always suspect this and go for an upper GI endoscopy. Coming to the treatment, it is discussed in, always remember, I'll always say this in my every class, that treatment should always begin with the medical management. So that is pharmacotherapy, then comes the interventional parts. Coming to pharmacotherapy, antibiotic prophylaxis should be started because there are chances of infection. So if the portal blood is infected, there are high chances of infective pathology in the liver. So to decrease that, you always give an antibiotic prophylaxis to the portal hypertension patient. So octreotide, which is a somatostatin analog, is also used, and it is effective as endoscopic treatment for control of acute variceal bleeding. So endoscopically, when you are doing, you can inject octreotide into the varice. So that has an efficacious effects based on the studies. So somatostatin analog like octreotide is used. So in severe cases of hemorrhage, again vasopressin can be used. This diminishes the splanchnic blood circulation. So splanchnic hypertension can be managed through vasopressin. So again, the entire idea is to manage the patient's HVPG, that is less than 12 mm of Hg. So other pharmacological agents like nitrates and serotonin antagonists and calcium channel blockers. So calcium channel blockers can decrease the blood pressures. So these agents can also be used, but the best are always the octreotide and endoscopic therapy combined with the octreotide therapy. And there is something called as variceal tamponade. This is done through Sengstaken-Blakemore tube. It is a triple E1 tube where you dilate certain balloons. That is, there is a stomach balloon and esophageal balloon present in the Sengstaken-Blakemore tube. You inflate those two. You compress the bleeding vein. So, in any surgery, our first dictum is for pressure. Be it any diameter of vessel, you always apply pressure to the bleeding vessel. So that in 50% of the more than 50% of the times, if it is a smaller vessel, it will stop. If it is a vessel with a larger diameter, your chances of stopping are get diminished, but you can always apply pressure and think for what you can do to stop the bleeding. So that same physiology applies in variceal tamponade due to the inflation of the balloon present in the esophageal part. This causes pressure over the bleeding vein. So immediate cessation of bleeding in more than 85% of the patients, and there are widespread availability of the device. So it is very effective treatment choice. So the disadvantage is it cannot be used in gastric varices. So esophageal varices is different from gastric varices. So gastric, the stomach being a very distendable part, you cannot do it effectively. You cannot use Sengstaken-Blakemore in gastric varices. And again, another disadvantage is you can stop the bleeding at that time, but after 2 or 3 days, that same bleeding vessel can always bleed back. So recurrent hemorrhages is up to 50% of the patient after balloon deflation, because you cannot keep the balloon inflated for more than certain amount of time. If you keep that balloon inflated for longer periods of time, what happens is it causes pressure necrosis over the mucosa of the esophagus. So this is again very deleterious effect. So if you keep balloon inflated more than a set of time, there is some kind of discomfort because you are navigating it through the patient's mouth. You always be in discomfort, and always experience is important for the operating person. Whoever is doing the procedure, he should be well trained in the procedure. So this is the Sengstaken-Blakemore tube. So this is the gastric balloon, and this is the esophageal balloon. So gastric balloon acts as an anchor. to fix the tube in the esophagus. So once it is fixed, you inflate the gastric balloon. So this is the gastric aspiration end, and here you have NG tube present accessory for any secretion, excretion, or some or anything. So endoscopic therapy I have already said to you. So apart from octreotide, you can always use sclerotherapy for the bleeder present in the esophagus. And this is clamping. So for suppose this, if you see a bleeder, you can always apply a clip to the bleeding varix. So that's that ceases the bleeding. So these are or all these things can be done through endoscopic approach, and it is minimal invasive and it is easy to do than operating. So all these are newer techniques that are being done. And the surgical part, in very chronic patients, we go for surgery. The last resort is always surgery. So there are certain shunting systems that are present to decompress the portal pressure. There are coming to the shunt systems. There are divided into radiological and surgical. So the radiological is the transjugular intrahepatic portosystemic shunt. TIPS infers to transjugular. You are going through the jugular vein. Transjugular intrahepatic portosystemic shunt. That is TIPS. And the surgical shunts are total, partial, and selective shunts. So this is done through radiology support. So you puncture the internal jugular vein and puncture the hepatic parenchyma and go into the portal vein. So when once the tract is created, the intraparenchymal tract is dilated, and entire thing is stented with an expanding metal stent of diameter of 1 to 1.2 centimeter. So coming to the success rates, if done correctly, there are success rates of more than 90%. So what you are doing here is you are making a bypass between internal jugular vein and the portal vein. So you are decreasing the pressure in the portal vein. Again, it is a temporary approach because it will have an effect for about 5 or mostly 5 years. Because most patients that need these kind of surgeries are always in end stage liver failure. So such patients are always waiting for transplant. So transplant can't be that is not in surgeon's hand or in the patient's hand. So it is based on the availability of donor. So such patients who are optimistic to wait for transplant, they go for TIPS. If they are lucky, they can get a donor and they will go for transplant. So the disadvantages are like any stenting techniques, there can be a stenosis of the stent. So the entire thing can fail. And shunt thrombosis can occur based on within the lumen of this thing, thrombosis can occur. So that is again a fatal complication because it will end up in pulmonary embolism. All these things are seen within the first year, but if you can manage the patient effectively for the first year, it is pretty much stable for the rest, that is approximately 4 to 5 years. In the newer technique, there are something called as usually do it with the metallic stents, but there are newer advances are coming, and covered tip stents have been implemented in the treatment. So these have reduced thrombosis and stenosis rates. So this is the tips. So through the IJV, you are coming through the portal vein, it's coming to the hepatic vein, and in hepatic vein you are penetrating the uh, hepatic parenchyma and going into the portal vein. So this thing you are shunting the systems. So here you can see varices which are present previous to the stenting. So after the stent is placed, the varices are decreased as the portal pressure is decreased. And then come to the surgical stents, that are total, partial, and selective stents. So based on the structure that are you doing, end to side portocaval shunt, portocaval. Always remember portal vein and caval is IVC, inferior vena cava. So that shunt is end to side to side portocaval shunt and mesocaval shunt. So as the name indicates, end to side is end to side anastomosis. So you are anastomosing the cut, you are cutting the portal vein and anastomosing it to the cava, to the vena cava. That is end to side portocaval shunt. Okay. So this is end to side portocaval shunt. You are cutting off the end of the portal vein and you are connecting it to the side of the IVC. This is end and this is side of the IVC. That is why it is called as end to side portocaval anastomosis or end to side portocaval shunt. And side to side portocaval shunt, the entire thing is same. You are bypassing and decompressing the portal system. This is the side to side portocaval shunt. Then in the side to side portocaval, there are again interposition parts like portocaval, so portal vein and the caval in the inferior vena cava. And two is mesocaval, that is mesenteric vein and the inferior vena cava. And mesorenal, that is you are decompressing through these things. That is anastomosing the superior mesentery to the inferior vena cava and superior mesentery to the renal vein. So anything you are doing, that is decompressing the portal system here. So this is prenorenal, again the same thing. So again, partial shunts, you can use PTFE grafts. So these are approximately about 2 to 3 centimeters long, and it gives a better anastomosis advantage. So PTFE is used in partial shunts. So here you don't need to anastomose directly the vein. So what they are doing is they are using a PTFE graft. So with that graft, they are anastomosing one end to the portal vein and anastomosing the other end to the inferior vena cava. While in total shunts, which I showed earlier, you are anastomosing directly the portal vein to the inferior vena cava. While as in the selective shunts, what they are doing is they are using a graft to bridge the process. So what are the benefits of doing this is you will have a better space between both the anastomosis, and there will be less tension between the on the anastomosis. There are less chances of leak, there are less chances of thrombosis, etc. So selective shunt is always the distal spleen or renal shunt. Always remember that. Whenever they ask what is a selective shunt, just say distal spleen or renal shunt. Most commonly done. This is the spleen or renal shunt. Their splenic vein is attached to the renal vein. So again, devascularization procedures. What you do is there are different varices and collaterals developed around the esophagus. So devascularization in term means you're cutting off them. You're cutting off the vascular part. So excess collaterals, you're knocking them off. So these things can be used when the patient has extensive portal and splenic vein thrombosis, and there are other operative, and there is no chance for other operative radiological options. So another operation is the mesorix bypass. All these are not that important to you. So just remember the total shunts and the partial shunts and distal spleen or renal shunt in operative parts. In the end stage, for any liver disease, the treatment of choice, the only treatment available for a fully functional and normalization of the patient is liver transplant. Nothing you can do, nothing that you can do can benefit the patient other than liver transplant. All the things which we are discussed earlier are makeshift procedures to keep the ball rolling. You you can just keep the patient survive for more longer, but you cannot guarantee his health with the above mentioned procedure. But liver transplant, if it is successful, is the only treatment present for a end stage liver disease patient. So the major issues for liver transplant is again the cost, patient selection. So there should be an availability of donor. And again, immunosuppression happens because you are transplanting a foreign object into a body. So there will be always be a chances of rejection. So to diminish that, you give the patient a immunosuppressive drugs. So if entire thing, the patient should be able to withstand all these things. So again, everything depends on the child pug and MELD scoring systems. Based on that only, you can go for liver transplant. So coming to outcomes, there are chances of 1 year survival about 80%. 80% of the patients can survive and be normal after liver transplant, and that decreases to 60 to 65% in 5 year survival. So that is about portal hypertension in brief. So in the entire thing, just remember the causes, that is pre-hepatic, hepatic, and post-hepatic, and the child bug scoring systems, uh, and the treatment which we do. So pharmacotherapy we go for octreotide and ultrasonography. Sorry, uh, endoscopic therapy combined with vasopressin or combined with octreotide or combined with sclerosing agents. So all these are minimal invasive techniques. So once it goes for a compulsory surgery, there are again total shunt, partial shunts, and distal splenorenal shunts. And the end stage is always liver transplantation. So that is in brief about portal hypertension. Thank you.